take a look at the appendix and all the other organs of digestion. So we're going to start off with the appendix, and one of the most common problems with the appendix, of course, is appendicitis. Appendicitis is usually the result of the appendiceal lumen becoming obstructed with something. It could be some sort of seed, like an apple seed, it could be some sort of hard fecal material, fecalith, or perhaps even can be caused by some sort of infestation of a parasite, or even a carcinoid tumor growing in the appendix. Whatever be the case, most of the time, appendicitis is caused by obstruction of the appendiceal lumen. When the appendiceal lumen is obstructed, bacteria start to grow in the lumen. They're producing gases, but the gases can't vent anywhere. And so they accumulate in the lumen, and they start distending the appendix. As the appendix distends, some of the veins collapse, and this results in high hydrostatic pressure, which causes appendiceal edema. That, in combination with the distension of the walls, eventually causes the collapse of arteries, and the appendix starts to become necrotic. As the pressure continues to increase, eventually the necrosis of the walls in combination with the force generated by the pressure, the appendix will rupture. In the context of the appendix, which is septic, dumps into the peritoneal cavity, and that will cause a septic peritonitis that will develop ultimately into a septicemia if nothing is done about it. When the appendix ruptures like that, we refer to it as a ruptured appendicitis, ruptured appendix. That's a surgical emergency. Once the appendix ruptures, you got about 2 hours to get in there, remove the appendix, and flush out the peritoneal cavity with antibiotics, usually neomycin, to prevent a septicemia from developing. Once a septicemia develops in an individual, it's difficult to operate on them, it's difficult to surgery them because of the high morbidity and mortality. You really can't surgery an individual who's septic if the morbidity and mortality is just too high. And so you would try to keep the septicemia under control with antibiotic. If you possibly could get it under control, then you can perform your surgery. Okay, so a ruptured appendix is considered a surgical emergency. You've got to get to everything before a septicemia develops. Okay. Now, when a appendix becomes obstructed and the gases in the appendix start to accumulate, the appendix distends. The appendix is not topographically mapped in the brain, so you feel pain associated with that appendiceal distension, but it's referred pain. It's referred generally around the umbilicus, so you feel periumbilical pain. As the appendix continues to swell, it becomes inflamed. That inflammation will involve the abdominal wall. As the inflammation spreads to the abdominal wall, there's a shift in the sensation of pain. It goes from the periumbilical region down to the right lower quadrant. And eventually, the pain will continue to increase in intensity. Will increase in intensity until finally the appendix ruptures. And at that time, a person will feel relief of pain. And so if someone has an appendicitis, they have all that pain and they suddenly feel a relief of pain, that may not be a good sign. That actually may be the worst possible sign that the appendix is already ruptured. Let's take a look at the appendix. So here we have a normal specimen and an inflamed specimen. Sometimes the appendix is described as being vermiform, meaning worm-like. And you can see a normal appendix here. This would be the proximal portion of the appendix attached to the cecum here. There's the distal tip of the appendix there. Looking down at this appendix, everything looks good. You're looking at the serosal surface, it's kind of white-gray, a lot of healthy blood vessels. The periappendiceal fat is good, and the appendix has a smooth, shiny, glistening surface. Doesn't look swollen at all. Okay. That's the normal specimen. Here is what an inflamed appendix looks like. Okay. That's proximal appendix. That's the tip of the appendix. And just one look at this appendix, you can see it's enlarged and it's erythematous. It's clearly inflamed. You notice the surface of the appendix is not smooth, it's not shiny, it's kind of granular, and it's very erythematous. And this is, of course, the appearance of an inflamed appendix. Now you notice that the inflammation of the appendix has not remained confined to the appendix. It's actually spread to the periappendiceal fat here. This should be yellow fat. You notice it's all red. This is what happens in appendicitis. The inflammation doesn't remain isolated to the appendix. It tends to spread in the vicinity of the periappendiceal fat and to the bowel. And eventually what happens with an inflamed appendix is a lot of tissues around the appendix tend to mat together. So if you actually look at a CT scan of someone with an appendicitis, you see this large matted mass in the right lower quadrant. That is the result of inflammation in the appendix spreading to other tissues, causing everything to stick together. Let's take a look at the histology of an appendicitis. Let's first again look at normal histology. So there is the normal appendix, that's a cross section. And you can see we've got, of course, the lumen over here. You can make out what looks to be, that looks like the mucosa right there. This is the submucosa. And of course, you can see the muscularis propria here. You expect to find some inflammation in the appendix. In fact, you expect to find inflammation throughout the entire GI tract. It's called normal physiologic inflammation. Sometimes it's called mucosal-associated lymphoid tissue, or MALT for short. That physiologic inflammation should be isolated to the mucosa and superficial submucosa. You shouldn't see it anywhere else. And if we look here at this appendix, you can see that there is some inflammation, that blue stuff right there, all inflammatory cells, definitely populates the mucosa, and some of it extends down into the superficial submucosa. So looking at that, looking at the distribution, yeah, that's inflammation, but I don't consider it abnormal. That's perfectly normal mucosal associated lymphoid tissue, normal inflammation. Okay? That's what the normal distribution of inflammation in the appendix should look like. So how do you identify abnormal inflammation of the appendix? To make your diagnosis, your histologic diagnosis of appendicitis, you look at the distribution of the inflammation. Take a closer look. Again, here's normal. You got the lumen out here, and you recognize this as mucosa. There's the mucosa. This would be the submucosa. And this down here, of course, is the muscularis propria, and you can actually see some serosa out here. Look at the mucosa. You can see all the blue staining inflammatory cells. You can see those inflammatory cells extend down into the superficial submucosa right there. You don't see very much down in the deeper submucosa, and you should never see inflammation down in the muscularis propria. Okay, this is all normal physiologic inflammation. And again, we call that MALT tissue. If that's normal, what does abnormal inflammation do? It's not so much the inflammation itself, but it's the distribution of inflammation. The distribution of inflammation in an appendicitis is transmural. It extends right down into the muscularis propria. You should never see inflammation in the muscularis propria. Okay? Again, there's the lumen. There's the mucosa, at least what's left of it. There's not much of it left. There's the submucosa. Again, you can see blue inflammation here. Okay, that isn't necessarily abnormal, but if you look at the muscularis propria, you see you've got these aggregates of lymphoid follicles in the muscularis propria. That doesn't do that. So if I see that, that gives me the diagnosis of appendicitis, at least histologically.
Dr. Maddox?
Yes.
Does it ever reach the serosa?
It reaches the serosa.
That's right.
For the serosa. In fact, you can see there's a little fiber in here, but this should be the serosa. You know what's left of it. You can see some here. Okay, let's take a look at a CT scan of appendicitis. So let's first take a look at normal appendix. A CT scan, again, anterior, posterior. There's left, there's right. And we're right in the lower pelvis. You can see the psoas muscles here. Looks like we got some small bowel fluid contrast here. We can see part of the sigmoid colon over here. This looks like sigmoid colon, descending bowel. You can see this contrast agent. There's an air pocket. That's normal to see air in the GI tract. Over here you can see the cecum. Again, it's filled with contrast, and you can see air pockets in the cecum. Hanging off the cecum, there's the appendix. Okay, hanging right off there. Everything looks good. Appendix doesn't look big. It doesn't look like there's any inflammation causing matting of any tissues. So that looks okay. Over here you got someone with an advanced form of appendicitis. Again, same thing, anterior, posterior. There's right, there's left. There's no contrast being used in this individual. I can see air here, and that seems to be contained in some loops of bowel, and there is some colon over here that's got some air densities in it, but it looks like all the tissues here are all fused together. Sometimes that's called matting. Everything is matted together, and that's because the appendix here is so inflamed that the inflammation is spread to the surrounding tissues, and as the tissues become inflamed, the inflammation causes these to fuse together. And so it's big matted everything. If you can find the appendix in there, it's usually a little challenging. Okay? In this case, we can see the lumen of the appendix. It's actually right here. Okay? And the only reason I can see the lumen of the appendix is because there's something radiodense inside that appendix. In fact, it's the very thing that probably caused the appendicitis. This is radiopaque dye that has formed a concretion. And apparently what happened to this person a month or so earlier, this person had a barium enema. The contrast agent was used, of course, to look at the bowel. Some of that contrast agent got in the appendix. Barium sulfate's not very water soluble, so sometimes it forms concretions, very difficult to solubilize. It formed a concretion in the appendix here, and it occluded the appendix, and that's what caused the appendicitis. Actually, the barium enema caused the appendicitis. And here you can see evidence of the residual barium within the appendiceal lumen. You can see what kind of damage this inflammation has caused. Simple appendicitis caused quite a bit of damage here. Okay, so we talked a little bit about the pathogenesis, the risk factors. Generally, if you're going to develop an appendicitis, it's usually earlier in life, and that's related to the anatomy of the appendix. The appendix is a smaller lumen, it's easier to obstruct. If you're going to develop an appendicitis, it's probably going to be early on. Okay, second, third decades of life, someone in their teens, someone in their 20s. Caused by luminal obstruction, and there's a list of things that can cause the obstruction. Fecalith, a gallstone. When the gallstone gets through there, tumor, probably a carcinoid tumor, parasite infestation. Sometimes the lymphoid tissue can become hypertrophic and obstruct. Okay. Presentation, we talked about that. The periumbilical pain, that's referred pain. As the appendix becomes more inflamed, it will involve the abdominal wall, and the pain kind of shifts down there to McBurney's point, right lower quadrant. Okay, there'll be other constitution signs and symptoms. There'll be a fever, leukocytosis, nausea and vomiting, everything you expect associated with the GI pathology. There are a number of tests, manipulating tests that you can perform to help confirm your diagnosis, or at least substantiate your diagnosis of appendicitis. They're listed there. None of them are reliable. None of them are very sensitive. None of them are very specific. If they're positive, great. You know, you've got the psoas sign, the obturator sign, Rovsing sign. That's fine. But if they're absent, that doesn't mean a thing. Okay, leukocytosis and fever, this is a significant systemic inflammation, so you expect the white blood cell count to go up, and there will be a fever. The biggest problem is when the appendix ruptures, because that results in a septic peritonitis that will develop into a septicemia, generally within about 2 hours. So the clock is really ticking once this thing ruptures. Okay. Again, the workup, leukocytosis with a left shift. You know what a left shift means, right? You got immature forms. Okay, so you have high count of white blood cells, plus you have a lot of immature white blood cells in the bloodstream. That's what the left shift means. Urinalysis, sometimes the ureters are involved. Yeah, everything gets involved by this inflammation. Okay, so you might see some hematuria, some pyuria. CT scan I showed you, preferably with oral and IV contrast, very sensitive and specific. It's not always possible to perform a CT scan with oral contrast agent because they can't hold anything down. Administering an enema might be dangerous because of the inflammation and the weakened bowel wall. You can actually cause a perforation if you increase the luminal pressure transiently. Ultrasound, if you can see the appendix with an ultrasound, that's a great way to diagnose. You probably start off with that because ultrasounds are all over the place. Okay, they're more readily available than a CT scan, really cheap. The problem with the ultrasound is that often you're trying to image an area that will be surrounded by air in the GI tract, and the air doesn't transmit the sound energy very well. So you may not get a really good picture of the appendix. Okay, the resected specimen, of course, you see inflammation. The inflammation is in a very pathologic distribution. Any questions on that? Okay. Yeah.
So I was like, I had appendicitis before and went beyond home without having appendicitis.
You had appendicitis?
And went away at home.
Possible the appendiceal lumen can clear itself. And did you notice anything, did you do anything unusual prior to developing the appendicitis?
I was eating a lot of fatty foods.
Fatty foods.
Like very, very fatty.
You didn't notice anything that was past, like a gallstone?
I was like 8 years old.
Oh.
They took me to the hospital for like a couple of hours and they were like, it'll pass. And then I remember like it hurt for a couple of days. And then they gave me some kind of medication, but I don't know what it was.
Did they confirm it was an appendicitis, or did they on their differential? Did you remember like an ultrasound or CT scan?
Nope. He just popped in and I was screaming in pain and he was like, okay. And I was going home later and slept all
Drink
They
some water.
kept you for observation for a few hours?
No, they just told me to check back with my doctor the next day. But even though they were
All right, well, I'm not sure what was going on there. What they were doing. Something else. Okay, so next section we want to take a look at are hemorrhoids, also known as piles. In fact, this country is the only country we refer to them as hemorrhoids. Everybody else refers to this condition as piles. Okay, so this is a condition where a person develops dilated submucosal anal and perianal veins. It develops in the hemorrhoidal plexus venous system, usually as a result of high intraluminal pressure, which can be caused by constantly being constipated, bearing down hard. Okay, that will cause high intraluminal pressure, eventually cause the distension of these blood vessels. Sometimes it's caused by pregnancy. The pregnant uterus can include venous return, increasing, again, the intraluminal pressure. It can also be just caused by portal venous hypertension. The portal venous system communicates with the hemorrhoidal plexus. Okay, very common after the age of 50, again, Some of the more common causes would be constipation and the venous stasis caused by pregnancy. We can subdivide hemorrhoids into two types. We got the internal hemorrhoids and we got external hemorrhoids. Again, hemorrhoids are caused by variceal dilations developing in the venous system in that area. The internal hemorrhoids occur above the anorectal line. They're the result of hemorrhoidal varices developing in the superior and middle hemorrhoidal plexus. Usually these are hemorrhoids you can't see on a physical exam. And then you got the external hemorrhoids. They develop in the inferior venous plexus. Problems with hemorrhoids. They can be eroded, they can bleed. And so one of the most common presenting features is just bright red blood per rack. Someone goes to the bathroom and they realize there's just pure bright red blood dripping. Okay. Other things, sometimes they get thrombosed and that can be painful for some. Okay, so painful that they actually interferes with their ability to walk. Let's take a look at these. Let's first take a look at these external hemorrhoids. Okay, so we're looking for venous. And you'll notice that we have these 1, 2, 3 masses here, kind of tumorous masses. Those are the submucosal veins. You're making me laugh.
Somebody else. No, I wasn't doing anything this time.
Oh, you're in it, okay. Innocent. Bulbous masses, and those are actually caused by dilated submucosal veins. They're kind of bulging out, causing the overlying tissue to bulge out. And again, these are external hemorrhoids. The internal hemorrhoids, normally you can't see. However, this image I'm going to show you is that of a prolapsed rectum, and this is an opportunity. You can see the internal hemorrhoids. So this is a prolapsed rectum, and again, you can see there are about 1, 2, 3 masses there. The hemorrhoidal tissue. Try and keep it in.
I'm trying not to disrupt the class. I'm sorry.
Trying to. These things are very vascular, and so you got a lot of convoluted veins in there, dilated veins, and so they become excoriated and they bleed. Okay, any questions on that? So the way to treat these things, if they're bleeding, you can use a vasoconstricting agent. Topical vasoconstrictor helps reduce the bleeding, also helps shrink the hemorrhoidal tissues. And of course, if they're very painful, you can use a topical anesthetic. Okay. That's how you treat these conditions. If they're really serious, someone might consider a hemorrhoidectomy, remove them. Person is, again, young, and young enough, I should say, and they're causing considerable pain problems, you might consider hemorrhoidectomy. Okay, anything on that? All right, so let's get to the liver. Some problems with the liver we have to talk about, including jaundice. Jaundice, we spoke of this earlier. Jaundice is caused by high levels of bilirubin. So hyperbilirubinemia causes jaundice. Normal total bilirubin level is about 1.2 mg per deciliter. And it's not until you get over about 5 mg per deciliter where you actually start seeing some signs of jaundice, also known as kernicterus. I should say icterus. Usually, if you're going to see jaundice, it's going to develop in the sclera of the eyes first. So you'll see a little yellowing of the sclera. That's probably where it's most notable. That'll happen around 5.5 mg per deciliter. You start to see change in color. For some, maybe it's a little earlier. Then when you start getting over 5.5, you really start to see that yellow discoloration of the skin that we recognize as jaundice. Okay, Now, to understand the etiology of hyperbilirubinemia, we really have to understand some of the general metabolic routes of bilirubin. Caused by bilirubin, high levels of bilirubin, we should understand how the metabolism of bilirubin can be disrupted in order to determine the etiology of the hyperbilirubinemia. Most of the bilirubin that we generate is from senescent erythrocytes, meaning aged erythrocytes. They contain hemoglobin. Hemoglobin is going to be broken down into bilirubin. Usually, senescent erythrocytes are recognized by the spleen or the reticular, the mononuclear reticular system. Okay, the splene's going to monitor for dysmorphism of the RBCs and some expressed glycoproteins, proteins on the surface of the RBCs. Determine if the RBC has outlived its usefulness. These RBCs have a lifespan of about 120 days, after which time the spleen is going to remove them. Spleen will break them down into different components, including heme. Heme is going to be converted to biliverdin by heme oxygenase. Biliverdin will be converted to bilirubin via biliverdin reductase. Now, this bilirubin that's formed is a very fatty molecule. It is not water soluble. Okay, yet it's got to get from the spleen to the liver, where it can be excreted. To do that, it's going to have to be piggybacked on albumin. So albumin is a globular protein, has little these hydrophobic niches. Bilirubin can hide in one of those little niches, and it's brought over to the liver. It's brought to the liver. The liver will absorb the bilirubin. There's actually a carrier protein that does that. The bilirubin gets into the endoplasmic reticulum of the hepatocytes, where it is conjugated to a molecule called glucuronic acid. Let's take a close look. This is what's happening in the endoplasmic reticulum of the hepatocyte. We have this very fatty form of bilirubin. It's called unconjugated bilirubin. Again, it's so fatty, it's not soluble in the cardiovascular component. It's brought to the hepatocyte endoplasmic reticulum. In the endoplasmic reticulum, it's conjugated to this molecule called glucuronic acid, which is just a carboxylic acid of glucose. It is conjugated to this molecule via the activity of an enzyme called uridine diphosphate glucuronidase also known as UGT. The unconjugated bilirubin gets conjugated to glucuronic acid by the activity of UGT, and you end up with what we call conjugated bilirubin. Conjugated bilirubin is amphipathic. It has an end here that is hydrophilic, and it's got an end here that's hydrophobic. That makes it amphipathic. And you know these amphipathic molecules, they can make micelles. They can emulsify other fatty molecules. In fact, that's one of the functions of conjugated bilirubin. It's actually excreted into the GI tract. If you have any fatty molecules in the GI tract, the fat can be emulsified, meaning you can break it up into micelles, and the micelles will be composing part of this conjugated bilirubin. Okay. Once a fraction of the bilirubin is conjugated, it's again excreted into the biliary canaliculi. Biliary canaliculi will emerge eventually into the common bile duct. Some of this bilirubin is going to be stored in the gallbladder with the rest of the components of the bile. Some of it's going to be dumped into the duodenal sweep, right into the GI tract, and again, some of that is going to be used to emulsify fats. Okay, eventually it goes through the small bowel. By the time it gets to the terminal ileum, a fraction of this bilirubin is going to be resorbed and brought back to the liver. That pathway where it's excreted and then resorbed is called the enterohepatic circulation of bilirubin. The rest of it goes into the large bowel. Some of it's broken down by beta-glucuronidases, eventually forming something called urobilinogen. and both intact bilirubin as well as urobilinogens can be passed in the stool. Now, it's actually this bilirubin that's passed in the stool that imparts the characteristic color of stool, brown, dark brown color. That's bilirubin. If there were no bilirubin in the stool would take on a kind of a gray-white color. Okay, that's what it looks like without bilirubin in it. Stool without bilirubin is referred to as acholic stool. And you can see what that looks like. I think I mentioned this before. If neighbor's dog or your dog kind of makes a little present, sits in this one, the bilirubin is bleached, and what's left over is what the stool looks like without bilirubin. It's kind of pasty white looking color. Okay. Let's talk about these two different fractions of bilirubin I mentioned. So I mentioned that sometimes this bilirubin is just a plain fatty molecule. And in other cases, the bilirubin is conjugated to glucuronic acid that makes it amphipathic. So at any one time, we have these two fractions of bilirubin. We have conjugated bilirubin, and we have unconjugated bilirubin. Together, that makes up the total bilirubin. When someone develops jaundice, you know they're going to have hyperbilirubinemia, but you're not going to know the etiology. However, if you measure the components of bilirubin present, you measure both the conjugated as well as the unconjugated bilirubin, knowing which one is present in disproportionately high amounts can give you a clue as to where the disruption in the metabolism of bilirubin is. Generally speaking, if you have a disruption in the metabolism of bilirubin such that it causes jaundice, generally speaking, any disruption in the metabolism proximal to the conjugation step will result in an increase in unconjugated bilirubin. However, if you have a disruption in the metabolism distal to that conjugated step, you'll notice that the hyperbilirubinemia is predominantly conjugated. And you immediately can narrow down your differential. So we'll talk about a few things that can cause this. We don't have much time today, but I'll just give you a couple of examples. What could disrupt the bilirubin metabolism proximal to the conjugation step? Well, sometimes you're making more bilirubin. Maybe this person has a hemolytic anemia, breaking down more RBCs than they should. That's going to generate more unconjugated bilirubin. They might develop jaundice from that. You'll measure the bilirubin, and you'll notice, oh, geez, the unconjugated fraction is high. Well, one of the reasons might be, well, maybe you got hemolytic anemia. What would happen if the person has a conjugated bilirubin? Well, perhaps there is some sort of obstruction in the excretion of bilirubin in bile. Maybe there's an obstruction here right at the ampulla, and you can't get rid of the bile and the bilirubin contained within it. That can cause jaundice. If you measured that bilirubin under those conditions, you'd find the person had a predominantly elevated conjugated. So again, proximal to the conjugation step, unconjugated, distal would be conjugated, yes.
Where is this conjugation step again?
Conjugation step is right there in the endoplasmic reticulum of the hepatic. Catalyzed by UGT. Okay, any questions on that? Yeah, it's a good place to stop. We'll pick up